Sheila, thanks very much, and good morning to all of you. Well, it's always somewhat remarkable to me to reflect upon the fact that compression sonography for acute appendicitis has been on the clinical scene for over 30 years. And the fact that I'm here speaking to you this morning about 6 new things for you to consider in this examination, I think implies several things. First and foremost is this is not a static or even mature technology. This is an evolving and dynamic one. And yet it's one that has an extraordinary high clinical impact factor. The fact that we can diagnose with an inexpensive, readily available, non-invasive technique with no ionizing radiation and either rule in or rule out appendicitis is incredibly powerful. And not just for the patient and the patient's family, but really for our whole healthcare delivery system. And moving forward, as we transition to a paradigm where we're going to be treating appendicitis just like any other form of colonic diverticulitis with antibiotics, this will become even more and more important. I have no disclaimers. So the new things that I'm going to talk to you about are largely in 2 broad areas: image acquisition and improving specificity of diagnosis. The first thing we have to come to grips with is the major limitation of ultrasound compared to CT, and that is our low rate of visualization of the appendix. You know, it's rare for us with the CT not to visualize the appendix, but it's all too commonplace with sonography. And visualization rates, at least in North America, have traditionally been in the 25 to 30% range. And that's really too low to really have an impact because, remember, we can't diagnose what we can't see. So most studies have been done in the supine position, and when you think about it, what are our options available to us to improve our visualization? They involved a different acoustic window and a different transducer. And in fact, we've got to employ both of these strategies. So let's just review a few highlights of the scanning technique. It's very important to take a brief history and ask the patient if they can, excuse me, to localize with a single finger where they hurt the most. Now, they may not be able to do that, but if they can, it's really important for us to scan in that area. And here's a young woman who points right to her umbilicus. And here we can see a hypoechoic mass superficially right in the periumbilical region. We want to take a brief history, certainly ask if this patient's had surgery. In fact, she had surgery, and this is, in fact, a lap port implant from endometriosis. And we see lap port implants from cancer as well. Ovarian and colon cancer are treated often laparoscopically, and it's important to look in those areas as well. This more elderly woman pointed right to her umbilicus, and here we can see a hypoechoic mass, not in the umbilical region, but in the region of the omentum. It's got flow within it, and this was this woman's presentation for her recurrence of metastatic breast cancer with omental caking from metastatic disease. And as Mindy so beautifully showed, this patient pointed right to the right kidney. There is a lobar area of increased echogenicity, a little fluid adjacent to that right kidney. And remember, the endotoxin of E. coli activates complement in the microvasculature, causing microvascular sludging. And so acute pyelo is, in fact, an ischemic lesion, often seen with a little adjacent free fluid. So pyelonephritis as well. Now, one of my favorite cases, and this gentleman came over to us for acute appendicitis, and the technologist immediately got me, and I went into the room, and this gentleman pointed immediately to his left mid-abdomen. Now, you're just thinking to yourself, wow, the ER docs at Stanford, they are amazing. They can diagnose acute appendicitis in a patient with situs inversus. Now, just hold on. So he points to this hypoechoic mass. It's quite vascular. And we can see that the mass has both it's associated with one interechogenic submucosal ring and a second interechogenic ring. So I was talking to the patient, have you had any surgery? And although he could not remember, his wife remembered, something that I'm very familiar with, actually. And he had had a scalp lesion removed, and this was his presentation for metastatic melanoma with a small bowel intussusception. So lots of different pathology. You have to scan where the patient hurts. But I think that the supine position is just too limited as our only acoustic window. And I want to really emphasize the value of direct retrocecal scanning for a retrocecal appendix with a steep LPO position scanning in the coronal plane along the psoas. So here's a CT to illustrate the nature of the problem. If we come from a supine anterior approach, we're going to run into a lot of bowel gas in the cecum, and we're going to miss this retrocecal appendix. However, if we scan the patient in an LPO coronal view and just come through the left flank, that appendix will now come into view. And I learned this the hard way a number of years ago. We scanned this patient in ultrasound in the morning, and I was on CT that afternoon, and we had missed it because there was all this bowel gas in the cecum here. And on the CT scan, there was clearly thickened enhancing appendix. No wonder we had missed it from an anterior approach. So I just went over, got the ultrasound machine, brought it right into the CT scanner, and this was a young patient who was very accommodating, let me do this. Not sure that would happen today, but here's that appendix right in that LPO position coming from the left flank approach. So we have to get behind the bowel gas in the cecum, and if we don't see the appendix in a supine view, don't stop. Keep going in the LPO to look specifically for a retrocecal appendix. Again, sometimes you'll be gassed out by the right colon, but that retrocecal appendix in the coronal view will often be seen parallel to the psoas, hence the psoas sign of acute appendicitis. Here's another example of normal appendices seen parallel to the psoas muscle, scanning along the psoas muscle in an LPO position. So if we don't see it in the supine, we have to go in the LPO. And here's a normal appendix seen in the retrocecal position, only seen scanning coronally. Now, after that patient, if we still don't see it, then we flip the patient back and do a second look supine. And while there's not an enormous yield, there is an appreciable yield. About 8 to 10% of the appendices will only be seen in this. Remember, we've shifted the bowel gas and given ourselves a new acoustic window. And so here is the proximal base of the appendix. We'll talk a lot about this a little bit later. We see this thickened hypoechoic lamina propria. That is diagnostic of lymphoid hyperplasia, which may or may not be associated with acute appendicitis. If there's obstruction of the appendix, this is a classic mechanism for distal appendicitis, if the distal tip of the appendix is fluid-filled. The point I want to make here, this appendix was only seen on that second look supine view, so we're using 3 views. Now, when we look at the data from our group that we published on this, this is a training period where we got all of our technologists up to speed, and then we implemented this 3-step positioning algorithm. Takes just about the same time. You can see dramatic improvement in our visualization on ultrasound, and we've maintained this high level around 50%, but look at the concomitant decrease in CT utilization. So this has a twofold benefit. 1, we're making the diagnosis either normal or abnormal appendix, and 2, we're not running up the cost of the healthcare system and radiating young patients who don't need it. Now, the second thing that I want to talk to you about is why should we be happy with 50%? That's still far below CT visualization. Can't we do better? What are the lessons that we've learned from CT about why we're missing all of these appendices? Well, we looked at about 200 patients in whom we still didn't see the appendix. And we looked at the CT, well, where is that appendix located? Maybe we're just scanning in the wrong area. And we looked to see a couple of things. First of all, we wanted to see what quadrant vis-a-vis the ileocecal valve was that appendix in. And we used the CT to have an anterior medial and a posterior medial and lateral compartments, and pay very attention to this posterior medial compartment. That's the money shot. That's where we miss things. Next, we looked at, well, what's its relationship to the iliac crest? Are we scanning high enough? And so we looked to see all these appies on CT that we missed with ultrasound in relation to the iliac crest. And finally, we looked at the depth from the anterior abdominal wall with a mathematical fudge factor for compression. So CT is not done with compression, but ultrasound is. So sort of get these 3 parameters. And here's what we learned and published recently. 20% of the missed appies were above the iliac crest. We weren't routinely scanning there. And 62% were in this medial posterior quadrant. posterior medial quadrant. That's really what we do. So after we've done everything, we've done our three-step positioning, we do a dedicated attempt to look above the crest, and then we need to scan in the posterior medial quadrant. But wait, there's more. What we also learned was that an appreciable number of the appies were too deep to seen within the purview of a 10 megahertz transducer. We needed to get beyond the depth of 6 centimeters. So the takeaway was basically we had to change not only the patient's positioning and where we scanned, but the depth of penetration by using a lower frequency transducer. And so scanning above the iliac crest, and then targeting that posterior medial quadrant and scanning with a 6 megahertz is really the way to go. And here's an example. We don't see it with a 10 megahertz. We do see the appendix in this. We've not been aided in this attempt by the obesity epidemic, so this is an example of where the 6 megahertz depth of penetration will allow you to see that appendix. And here's a patient we're scanning above the iliac crest and was not seen below the iliac crest. All right, so one of the things that I mentioned is that antibiotic therapy will become very important as primary therapy, just like all other forms of uncomplicated diverticulitis. And what's really key is figuring out who's got gangrenous or perforated appendicitis, because they're not appropriate for short-term, potentially transitioning to outpatient antibiotics. They need either inpatient IV antibiotics or surgery. So this differentiating of complicated versus uncomplicated is very important. When I use the term complicated, what I'm really talking about is gangrene, that is a necrotic appendix, or perforated. So we had a hypothesis about that, and we said, just like with the gallbladder, if we lose that mucosal reflectivity in areas of gallbladder necrosis, it probably is going to be similar in the appendix. And if we lose our echogenic submucosal layer, let's use that as our operative paradigm for complicated appendicitis. And so this is what we did. We looked at a series of patients who had an intact submucosal layer and those that didn't, absent SML, and this turns out to be an extremely powerful discriminator. Here we can see an intact submucosal layer. Here we can see the complete loss of the submucosal layer in a gangrenous appendix. And here's that patient's path slide with the necrotic area, secondary findings, often thickened echogenic fat, and complete loss of the integrity of the bowel wall with inflammation out into the fat here. So an excellent discriminator. And here's a study from our group that we published showing that this had an extremely highly associated factor. If you lose your SML, highly likely to be complicated appendicitis. Conversely, if that SML is intact, highly likely to be uncomplicated. So that's very useful going forward. Now, as we look into more objective criteria for interpreting sonography, we have to come to terms with the fact that our old criteria of maximum outer diameters are imprecise. We know that below 6 millimeters, it's virtually always normal. We know that 8 millimeters and above, virtually always abnormal. But there's a gray zone in this intermediate area, and we have to use secondary interpretive signs. And those are either going to be color or fat. So this borderline category, we can't always tell. Now, as it turns out, when you look at large groups of patients, we looked at several hundred patients in this category, about 2/3 will have appendicitis, but about 1/3 won't. And sending a third of the patients to surgery is just unacceptable. So we have to have better discriminatory value in this borderline category. So how are we going to do that? Well, the first thing is to try to precisely define our criteria for normal or abnormal color flow in the appendix. It used to be with older generations of color Doppler, we couldn't really discriminate flow in the wall. Now we can. And we can see these areas of what we call dot flow. And these are the vasa recta from the arcades in the mesoappendix. And we can see these focal little areas. You can actually get spectral tracings for those. But contrast that kind of dot flow with this continuous curvilinear flow. And we began sort of anecdotally to sort of see that this was far more associated with appendicitis than this. So we wanted to test that as a hypothesis. What was the significance of dot flow versus this curvilinear flow? And we define this as contiguous 3 millimeter or greater flow in the wall of the appendix. And some examples, again, dot flow, curvilinear flow. So this is what we looked at with our hypothesis. And a study from our group showed that worked pretty well. In fact, dot flow, and we honed in on, again, this borderline category. I mean, if your appendix is 9 millimeters, it's acute appendicitis. Conversely, if it's 5 millimeters, it's normal. So where we really struggle, or again, on this borderline category, and this is where we want to see if flow can be more precise. And the data really show that this type 1 flow, or dot flow, is not associated with acute appendicitis. It's often seen with another thing we'll talk about, lymphoid hyperplasia, but I'm getting ahead of myself. So this curvilinear flow, greater than 3 millimeters, highly predictive, highly associated with acute appendicitis. All right, well, let's push that a little bit further. If we're able to visualize flow in the wall, why don't we get more and sort of view it qualitatively? Why don't we get more quantitative data? Why don't we push this even further and get spectral Doppler tracings? So what is the role of spectral Doppler in acute appendicitis? Now, when I was a surgical intern, this is what we refer to as a white owl. It's a normal appendix. It has sort of a gray, sort of dull surface. And this is what we call the injected appendix. And notice the difference here in the serosal vascularity. Not only are there more vessels, and they're more conspicuous because they're larger, but they're also tortuous. So vascular enlargement, tortuosity. To us, that just means, well, there's inherently got to be just more flow in that. And this might be reflected in the spectral Doppler tracing. So that's the hypothesis that we wanted to check. And in fact, when we look biochemically at the pathophysiology of acute appendicitis, one of the things that we learn is that there's vasoarterial dilatation mediated by histamine. I will just say as an aside that uncomplicated appendicitis sort of ends with this kind of inflammatory cascade. But gangrenous and perforated appendicitis are almost a separate disease. Very early on in that disease, they have upregulation of interleukins and cytokinins, interleukin 6, interleukin 16, and the metalloproteinases that cause rapid tissue lysis. And our old paradigm of, well, we've got to operate early or they're going to perforate under eyes is completely wrong. They have a separate metabolic cascade in terms of the inflammatory cytokine mediators. And they perforate and they have this rapid tissue necrosis way before they get admitted. So it's a completely different end pathway. But for the uncomplicated cases, we see this histamine-mediated vasoarterial dilatation. And that is reflected histologically in this marked dilatation of these serosal vessels. That's what you're seeing on the surface. That's what the quote-unquote injected appendix looks like. Now, the other thing that we learned when we started to look more carefully at the histology of the appendiceal wall, and our pathologists were really, they put up with a lot with me, you know, but Jerry Berry in particular I want to give a shout out to because he carefully looked at the walls of a lot of these patients. And what he found was that the veins were virtually always compressed by intramural inflammation. So concomitantly, there was both vasoarterial dilatation reflecting increased flow, and venous outflow obstruction. So what does that mean from compression of the mural inflammation? So what does that mean in terms of a hypothesis of what would we expect to see in the flow? Well, we would expect to see a higher peak systolic velocity, yet with high resistance flow. And so that may be a bit counterintuitive because we think of inflammation often as having maybe high diastolic flow. But if you go back to that histologic slide, that venous outflow compression really results in high RIs. So this is our hypothesis, that we would have increased peak systolic velocity, but with high RIs. And that is, in fact, exactly what we saw. And so when we look at these waveforms, we can measure them from the wall, and we can get a nice Doppler waveform. I'll just say parenthetically, the angle correction doesn't buy you any greater specificity. We angle corrected a whole bunch of these and non-angle corrected. So when you angle correct, if anything, the velocities are a bit higher. So it's not absolutely mandatory to angle correct, but if you can, we try to do it. here we can see the velocities here. So here's a quiz for you. Which one of these patients with a borderline MOD, maximum outer diameter, in fact has acute appendicitis? And here's a patient with a low peak systolic velocity. And here's a patient with high peak systolic velocity and high resistance. Well, as you might suspect, this is the patient with acute appendicitis with high peak systolic velocity and high resistance. And that's exactly what we see in this spectral Doppler waveform. Again, a borderline appendix. Between 6 to 8, we have to bring in secondary criteria. There's no real obvious increased fat, but the flow is abnormal. Both, we see the curve sign, it's greater than 3 millimeters, and we see this pattern of high peak systolic velocity, high resistance. And here are just other examples, et cetera, et cetera. And again, with the histology, the venous outflow obstruction. So we put this hypothesis to test, and we, by adjusting a lot of ROC curves, came up with discriminatory values, and pretty much, 10 to 12 centimeters is a pretty good cutoff for peak systolic velocity. If you're above that, very likely you have appendicitis with a specificity almost 90%. And that seemed to perform just slightly better than the RI. The RI was not quite as discriminatory. So this is impressive in radiology from our group. So again, we can use the spectral Doppler tracing to either further our diagnostic specificity. Now, one pitfall that has been problematic, and we've made mistakes with this in the past, is this entity of lymphoid hyperplasia. So let's drill down a little bit about that. The normal appendix has an abundance of T lymphocytes in the lamina propria. It's very interesting in terms of the immune function. If you have an early appendectomy, you have a much higher incidence of ulcerative colitis. And so there are all these T-cell immune modulators that we're just beginning to understand. So it may impact the gut biome. It may have different kind of immunological effects downstream. But here's an advantage of ultrasound that CT will never be able to compete with. We're able to see these layers of the bowel wall. We can see the lamina propria, which you'll never be able to do. It's this hypoechoic layer, and it should be it should be just about a millimeter. If it's 3 millimeters or greater, that's abnormal. So this is what we see. The wall of the appendix is completely replaced by this lymphoid tissue, and it compresses the echogenic submucosal layer and really attenuates the submucosa. So the striking feature of the wall is this thickened hypoechoic lamina propria. That is diagnostic of lymphoid hyperplasia. Lymphoid hyperplasia may or may not be associated with acute appendicitis. So we sort of have to figure that out in just a moment. When it is generalized, just think of the appendix as a large lymph node. This child's had rotavirus, and the lamina propria T-cell lymphocytes are just turned on. And if it's generalized throughout the entire appendix, even though the appendix is thickened, don't diagnose acute appendicitis. So when it's generalized throughout the whole appendix, that's just lymphoid hyperplasia. Now, as you might suspect, if those lymphoid follicles hypertrophy, this will be non-compressible. It sort of increases the resistance and stiffness when we compress. But these can be up to 7 millimeters. And this was called abnormal, and this was completely normal other than lymphoid hyperplasia. Now, there's a proximal form of lymphoid hyperplasia that I just want to tell you about that does cause, classically, tip appendicitis. And so here we can see in this patient in the proximal, there is a little bit of dot flow. That doesn't help us so much. But the lumen is compressed. That echogenic luminal interface is compressed by this thickened hypoechoic layer, the lamina propria. But distally, the appendix is swollen. There's distal appendicitis with fluid around it. Here you can see the lymphoid hyperplasia obliterating the luma, and there's distal appendicitis in that patient. And finally, just another example of distal tip appendicitis, marked thickening of the lamina propria obliterating the proximal lumen. And there's distal, both echogenic fluid and gas at the tip. Again, we're seeing this in an LPO position because it was a retrocecal appendix. Notice that there's some gas in the appendix, and seeing intraluminal gas in the appendix may or may not be acute appendicitis. If there's secondary signs of appendicitis, it may be a gas-forming infection. So here's an example of distal appendicitis related to lymphoid hyperplasia. So lots of new things that are happening with an old technique, and I hope that you'll reflect upon some of these things and incorporate them in your practice. And thanks to Sheila and the SRE. Thank you very much.